The pharmacology of the respiratory system, part 2. The GOLD guidelines. We alluded to those. These are the guidelines that are issued in regards to the management of COPD. There's several of the videos that review these very nicely, and a fair percentage of the time spent in primary care is taking care of people with this illness, unfortunately. Smoking cessation. So when you have someone come in and they have COPD, or you're worried that they're going to develop COPD, the most important thing that they can do for their health is to stop smoking. This will decrease the risk of heart disease, decrease the risk of a number of different cancers. There is nothing that anyone can do that will help their health more than stop smoking. So what's successful? Well, cold turkey is about 4 to 7% successful. So in people that quit cold turkey, about 1 in 20 will still be quit about a year later. Nicotine replacement is about 50 to 70% better than that. So that makes it about 10.5 to 12% successful. So a little less than 1 of 10 will be smoking, will not be smoking a year later. Bupropion, which is Wellbutrin, which is an antidepressant, even though if you order it as Zyban, it actually will have them give different prescribing information to the patient. Bupropion is about 25 to 30%, so almost 1 in 4 to 1 in 3 are successful at the end. Varenicline, which is Chantix, about 35%. There is no cumulative benefit. A lot of people think, oh, I'll have them do bupropion and varenicline. Most of this is overlap. There's really little, if any, difference in using the two than just using the varenicline. The varenicline, to the best of our knowledge, is an alpha-4 nicotinic receptor, alpha-7 nicotinic receptor, and a beta-2 nicotinic receptor. So basically, the types of receptors that are blocked are the types that are felt to be the types that cause urge for smoking. There's other medications that you can use. A lot of patients are scared to death of Chantix because they've heard of side effects. They may have tried the Zyban or bupropion. Nortriptyline and clonidine have probably a 5 to 10% success rate, modest. Fair amount of side effects for both of them. Clonidine, of course, has pretty dramatic blood pressure lowering capabilities, although you can get a rebound hypertension if they start it back up after being off for a little bit. So smoking cessation, very important. Keep working on it. Other infections related to the respiratory condition. Make sure you diagnose before you treat. Is it bronchitis or is it pneumonia? What organism do you think is causing it? Now, unfortunately, we often cannot have a definite diagnosis, and we will need to treat empirically. But the more you can try to get a good, effective diagnosis using laboratory testing, chest x-rays, etc., the better. Use the drug of choice for something. So don't just go by tradition, actually know what the drug of choice for particular conditions is. So bacterial pneumonia. The most common community-acquired pneumonia that we'll see is strep pneumo, also known as pneumococcus. You need to cover for this. Unfortunately, there's a number of other possibilities, and so you will need to go more broad spectrum. Good coverage for strep pneumo is usually just the basic penicillins, but unfortunately you do need to go broader than that. If there's an infection, if it's just located in the bronchi, it's bronchitis. Thus, bronchitis will not necessarily have any abnormal lung sounds, because usually abnormal lung sounds come from a disorder in the parenchyma. It may have some coarse crackles, what some of you might think of as rhonchi. The reason I don't use rhonchi is because the Lancet wrote a editorial about 25, 30 years ago that suggested that when people say rhonchi, they always assume that it's mucus and infection, and when they say RALS, they always assume it's fluid, and unfortunately, these often don't correlate to tissue diagnoses when a patient has those conditions. So just be careful using those terms. I use the terms fine and coarse crackles and assume that either one can be either one. If you have an infection and it influences the lung parenchyma, by definition, that's pneumonia. People that are pneumonia are usually sicker. They usually have some consolidation in their lungs. If you use egophony or bronchophony, you can usually determine it that way. It is a clinical diagnosis, however. It is a diagnosis that you make based on an accumulation of evidence, and then you make the call. Chest x-ray changes are not essential to make the diagnosis of pneumonia, nor does everyone who has a chest x-ray that looks like pneumonia actually have pneumonia. So keep that in mind. Use a chest x-ray appropriately. So what kinds of things can cause pneumonia? Just to review, bacterial is the most concerning one, but there's a lot of viral pneumonia out there. Mycoplasmal pneumonia, which is sort of halfway between a virus and a bacteria. Don't forget, mycoplasma does not have a cell wall, so you can't use a cell wall medication. What kinds of patients get mycoplasmal pneumonia? People that have a non-productive cough for 2 to 3 weeks. We'll talk about that in a minute. Weird things can also cause pneumonia, such as pneumocystis, what used to be carini, which is now Girocovi. And basically, when someone has these unusual infections, you have to think of immunosuppression and especially HIV. Aspiration is not uncommon. You will see people who are choking. Remember that silent aspiration also happens. And if you have someone that has risk factors for swallowing, you do need to keep that in mind. Certain appearances on the chest x-ray, an upper lobe, and especially on the right side, makes it a bit more likely to be aspiration pneumonia. When in doubt, carefully review your x-ray reports and maybe even discuss it with a radiologist. Other things that might cause bacterial pneumonia, Staph aureus can, but almost always if you get a culture that shows Staph aureus, it's contamination, unless you have a patient that has immunosuppression from cancer. It's an unusual cause of bacterial pneumonia, but it can happen. Lots of other gram-negative bugs, H. flu, Klebsiella, Pseudomonas, and especially gram-negatives are more common in smokers. Thus, you do often have to use a medication such as Bactrim for exacerbations of chronic bronchitis, just because you do need to cover for those gram-negative bugs. Legionella is an unusual gram-negative rod. It is waterborne. These folks usually do have confusion and diarrhea. The only time we really diagnose Legionella is when people are real sick. The milder version of this, in which patients usually can fight it off on their own, is called Pontiac disease. It had a recent outbreak in southern New Hampshire, but it's not a terribly hard bacteria to kill once you know exactly what you're dealing with. And then walking pneumonia. Lastly, these people have a dry cough for 3 weeks or so. They are still walking. They're still working usually. They still feel okay. Antibiotic choice, usually the first line is a macrolide, most commonly azithromycin. The other thing to remember when someone has a dry cough for 3 or 4 weeks is that in adults who have passed their immunity associated with their pertussis vaccine, this could in fact be pertussis. An adult essentially is never going to die of pertussis. A 1-year-old has about a 1 to 1.5% chance of dying if they have pertussis. Not terribly high, but bigger risk than most of us would take with our own children. So this is why you need to keep the Tdap vaccine up to date. This is why in someone who has this persistent dry cough, we'll often put them on a Z-Pack just to make them less communicable and less likely to pass on a pertussis. Lots of other things to think about in relation to infections and respiratory, but I think that this gives you the basics. And any other comments or suggestions, please let me know.